So on continuation, let's talk about the electrodiagnostic test. Okay, so we were talking about some of the variants. So let's revise some of the variants. So we talked about Miller-Fisher syndrome, where we talked about a triad of areflexia, ataxia, and ophthalmoplegia. Then we talked about Oman, AMAN, which is acute motor axonal neuropathy. Okay, acute motor axonal neuropathy. We talked about MSAN means acute motor sensory axonal neuropathy. Okay, we talked about AIDP means acute inflammatory acute inflammatory acute inflammatory demyelinating polyneuropathy. Okay, demyelinating polyneuropathy. We talked about Aman is acute motor axonal neuropathy. Okay, is it clear till here? Now CSF finding, we need to know that in CSF there's a albuminocytologic dissociation. Okay, so there's more amount of proteins and there's less amount of WBCs. Okay, now electrodiagnostic test. So what are we going to do in the electrodiagnostic test? So it might be normal. Lags behind the clinical events. Sorry. In demyelinating pattern, the earliest feature are prolonged F waves latencies, prolonged distal latencies, and reduced amplitudes of compound muscle action potential. Later, slowing of conduction velocity, conduction block, and temporal dispersion is seen. Okay. In a nutshell, electrodiagnostic test may be normal, may be abnormal. Abnormal, what can be seen in the case of abnormal pattern? In abnormal pattern, there can be decrease or slowing of the conduction velocity. Okay. Next is laboratory tests are helpful primarily to exclude mimics of GBS. Okay. So you can basically exclude GBS. Okay, secondary laboratory test. Electrodiagnosis features may be minimal and the CSF protein level may not rise until the end of first week. Okay, so you have to do this at the end of first week. By the end of first week only you are going to do this thing. Okay, so suspected treatment should be initiated without waiting for evolution of characteristic electrodiagnostic and CSF. So if the diagnosis is clinically suspected, just treat the patient. Okay, there is something which is known as a Brighton criteria. Brighton criteria, very very important criteria. Brighton criteria, BRIGHTON. There is Brighton criteria for Guillain-Barré syndrome. Brighton criteria. So Brighton criteria states that there is bilateral and flaccid weakness of the limb. So there is bilateral and flaccid weakness of the limb. Okay. There is decreased or absent deep tendon reflexes. It's a monophasic illness pattern and interval between the onset and nadir. Okay. Interval between onset and nadir of weakness between 12 hours and 28 days and subsequent clinical plateau. Monophasic illness pattern and interval between the onset and the nadir of weakness. So basically the onset and the nadir of weakness which it occurs in 12 hours to 28 days. Okay. Now electrophysiologic findings consistent of GBS. Okay, electrodiagnosis can be done with regards to GBS. There is cytoalbuminologic dissociation and absence of alternative diagnosis for weakness. So this is known as Brighton criteria. Okay, Brighton criteria. Okay. So let's talk about the treatments. Very very simple, and we just have 5 slides. Okay, 5 slides for treatment. Let's talk about the treatment. So in a nutshell, first of all, let's revise what we have talked till now, so that it becomes slightly easier. Let's revise till the treatment as fast as we can. Okay, So this is Guillain-Barré syndrome. It's a polyradicular neuropathy. It's an autoimmune condition secondary to the GM1 myelin component. Okay, so it's autoantibodies. It is always preceded by some sort of infection. It can be a GI infection, or it can be a upper respiratory tract infection. Basically, there's activation of interferon gamma, interleukin 2. Okay, so we have to always rule out certain sort of immunization. Guillain-Barré syndrome is prior to some viral infection secondary to Epstein-Barr virus, cytomegalovirus, okay, or it's a Zika virus, okay. Campylobacter jejuni is there, so there's HIV, SLE pattern is seen. Fever is actually not seen, okay. Fever and constitutional symptoms are absent at the onset of illness, okay. And remember that recent immunization must be ruled out. Motor symptoms are there. Diphtheria and reflex are auriflexia. Trigeminal nerves, there is a facial nerve weakness, and there is a ophthalmoplegia in the case of Miller-Fisher syndrome. Sensory system is basically being involved. Bladder discontinuity, bladder voiding abnormality may be there, secondary to bladder dysfunction, okay. And what next? We have to also talk about the pain. So pain is also present in the Guillain-Barré syndrome, okay. It's a the pain goes from the neck and to the back diffusely over the spine. Autonomic involvement is seen. AIDP is seen, acute inflammatory demyelinating polyneuropathy, acute motor axonal neuropathy, AMSAN, that is acute motor sensory axonal neuropathy. Miller-Fisher variant, there is 3 triad, okay. Lab findings is seen. Albuminocytologic dissociation, okay. Albuminocytologic dissociation as a lab finding. Then what do we have next? We have electrodiagnostic test can be done. Then what you need to remember is this is the Brighton criteria. Treatment is initiate as soon as possible. Okay, now let's come to the treatment very properly. Initiate as soon as possible. Each day counts. 2 weeks after the first week you can see some electromyographic changes. And the most important thing is you can see CSF protein level by the end of first week, okay. So if it's initially clinically diagnosed that this is GBS, just go for a treatment, okay. So initiate treatment as soon as possible. 2 weeks after the first motor symptom, immunotherapy is no longer effective, okay. Main state of treatment is intravenous immunoglobulin. So this is the main state of treatment, okay. And plasmapheresis, you're going to just remove all the plasma which consists of autoantibodies, and you're going to keep the plasma which is fresh, okay. A combination of the 2 therapies is not significant better than either alone, okay. So plasmapheresis and IVIG is the one which gives a better. IVIG is the most often the initial therapy chosen because of its ease of administration and good safety record, okay. IVIG is administered as 5 daily infusion for a total of 2 gram per kg body weight, okay. So how can you remember like this, okay. IVIG 1 1 2 gram per kg body weight, okay, like this. However, you just need to remember. So IVIG is administered as 5 daily infusion for a total dose of 2 gram. So this is a total dose, okay, total dose of 2 gram per kg. Plasmapheresis usually consists of around 40 to 50 ml per kg plasma exchange 4 to 5 times over 7 to 10 days, okay. Meta-analysis of randomized clinical trials indicates that treatment reduces the need for mechanical ventilation by nearly half. Significant improvement may occur towards the end of first week of treatment, may be delayed for several weeks. However, lack of noticeable improvement following a course of IVIG or PE is not an indication to treat the alternative treatment. In case of relapse, usually within a month, brief retreatment with the original therapy is usually effective. Glucocorticoids have not been effective in the case of Guillain-Barré syndrome, okay. Skin care, prevent bed sores, prevent joint contracture, go for exercise, ventilator support, attention to the vital capacity, airway management, chest physiotherapy, nutrition, and DVT prophylaxis, okay. Now this completes Guillain-Barré syndrome. What you should understand, IVIG and plasmapheresis is the mainstay of treatment of Guillain-Barré syndrome, okay. Thank you.